Hello everyone, good evening. My name is Dr. Michael Wright. I'm a GP in East Sydney and I'm the chair of Central Eastern Sydney Primary Health Network. I'll be your facilitator tonight in CESPHN's coronavirus update. Thank you for joining us. I'd like to start by acknowledging the traditional custodians and sovereign people of the lands across which we work. We recognise their continuing connection to land, water and community and pay respect to elders past, present and emerging. We also extend that respect to any Aboriginal colleagues who may be joining us today. Well, a lot has changed since we had our last CESPHN COVID update in person about a month ago, and meeting you all over webinar and dealing with a number of changes in the way we practice general practice, primary care and our whole health system in the last month. And tonight we're joined by not only some primary health practitioners in the Central and Eastern Sydney region, but also guests from surrounding PHNs. So welcome to our webinar. For those of you who practice within the CESPHN boundaries, you'll be emailed a link to an evaluation at the end of the session. So please complete that, including if you have any issues with the technology. Tonight, once again, we're going to have a series of presentations from local GPs, representatives from local public health units and from CESPHN, providing a series of brief updates before we open up for a panel discussion. We're really keen to your experiences during this pandemic and to understand where things are working and where they're working less well. Most of our speakers have been asked to speak for about 10 minutes and hopefully we'll have time for a couple of questions at the end of each presentation. If you have a question, please submit it in the question box on your screen throughout the webinar. Unfortunately, we can't put everyone off mute with over 200 people attending. Our last session, as I said, is about 40 minutes for panel session where there'll be an opportunity for further questions. If you're having any trouble with your audio or video, please check your internet connection and try reloading the web page. Everything has been working smoothly and hopefully it continues to do so with over 200 attendees. Unfortunately, we can't troubleshoot individual connection issues, but please mention it in the evaluation if you have any problems. Our first two presenters are going to present updates from the local public health district. So the first of these is Dr. Lena Gupta, who's Director of the Sydney Local Health District Public Unit. And our second presenter will be Dr. Vicky Shepherd, who's the Deputy Director from Southeast Sydney Local Health District. I'll ask Lena, would you like to start?
Hi everyone, I'm hoping you can all see me and it's nice to be able to speak to you. I've been asked today to just give you a bit of an update from Sydney LHD of some of the data that's coming in for Sydney Local Health District and some of the issues that we're addressing in Sydney LHD. And I'd just like to say it's been a really good partnership so far with general practice and with the PHN, and we really value that. So I'm hoping my screen now comes up. Did my screen just come up then?
Yes, it's there.
Okay, I'm not seeing it though. Excuse me while I get the technology right. I'm only seeing me. So I can't actually see my screen at the moment, everyone. So, but can someone assist me with that?
Lena, can you try minimising? Yeah, there you go.
Yeah, it's done it. Okay. All right. Pause the tape. Right. Apologies for that. So as you know, you've probably seen this data and everybody's been sort of keeping an eye on what's happening on Twitter and the internet, but you know, we are in a global pandemic. There's nearly 2.5 million confirmed cases in the world and 163,000 deaths, and there seems to be a little bit of plateauing. This is data from the WHO showing a little bit of plateauing worldwide, but you know, still we're in the peak of a pandemic. If we go to some Australian data, I know this is a messy slide, so I've just highlighted two things that I'd like to highlight. You know, we've got about 6,600 cases in Australia, and our epidemic curve, which is the highlighted section in the middle, looks quite different, where we've had this rise quite rapidly of cases, but then with a lot of measures that we're all experiencing at the moment, we are currently seeing quite a rapid decline. And in New South Wales, we have had nearly 3,000 cases, and you know that's certainly a lot less than in many other countries. But what concerns us a little bit is that of those 3,000 cases, over 350, we haven't been able to identify a contact. So obviously if there are cases that have had contact with someone who's already been unwell, or if we've had people that have travelled overseas, we might expect a case. But we've got some evidence that there's been some local transmission in New South Wales highlighted by those figures. So this just sort of shows this a little bit better. If we look at the locally acquired cases, which are in the dark area of this epidemic curve that I've shown earlier, you'll see that, in fact, we're still getting quite a bit of a peak of cases. So we're still getting local transmission, but substantially less than we were before. But they're the ones that we're really concerned about at the moment, because it means that we've still got circulating infection in our community. I thought I'd just present some state data that's just come out in the last day or so about case outcomes, again showing what's happened with these nearly 3,000 cases. And we know that 60% so far of those 3,000 cases have recovered, and we still have information to collect on others. But you know, the mortality rate that we've seen so far is about 1%. So that is lower than what's been seen in some other settings in other countries. So what we're doing in Sydney LHD and in New South Wales as a whole is a very much comprehensive public health response, which is a whole of government response, but it's also involving general practitioners, it's involving the community and all clinicians. The focus at the moment has been on testing, and I'll talk a little bit about that later, but then on case and contact management. So when we get a case that's notified to us or a positive test result, we are very active in interviewing that case and finding out where that case has been, what they've done, who they've been in contact with, and putting the case and close contacts into isolation. And close contacts are put into isolation for 14 days from the time of when they were exposed. And an important part of that now in terms of our case management is making sure that we tell the case, because we often get these results very late at night, to let their GP know the next morning. Often isolation is tricky, whether it's for cases or contacts, and we provide support for people in isolation where we can. We actually have some accommodation available for people who can't isolate safely from their family or their household, and we offer that. And of course, there are the social distancing measures that we're all experiencing and aware about, and I won't go into much detail about those. One of the things that I think Sydney LHD is unique for in New South Wales is our health hotels. So you may be aware that there are now quarantine restrictions for people who are flying in from overseas or have come from, off a cruise ship. When they do, they come into what's called police hotels, where they're in mandatory quarantine under the Public Health Act for 14 days. But some of them become unwell, and if they do, they're swabbed, and if they test positive, them and their family then get moved to what we call health hotels, which are in Sydney Local Health District, and we're managing those. And we've actually got about 450 beds. And Owen Hutchings from RPA Virtual will be talking a little bit about that later, because essentially what we've created is a mini hospital for patients while they're in quarantine, and they're monitored by RPA Virtual while they're in quarantine. And at the moment, I think we have about 60 people who have tested COVID positive from all over the state and the country who are in our hotels being monitored. The other part of the public health response is thinking about our vulnerable groups. We've done some work already with boarding houses, some screening, also just liaison with boarding houses about how they might manage isolation in the event of a case being positive. Group homes, we've done some work this week with the Exodus Foundation, and we've also done some work in supporting people who are in the at-risk age groups, provision of meals, etc. A critical area for us is residential aged care facilities, and we've worked very closely with GPs and the facility managers to make sure that we're really on top of any respiratory symptoms, getting people swabbed quickly if they have respiratory symptoms, following those results. And obviously we've been fortunate that we haven't had any cases in Sydney LHD nursing homes, but if we do, we're prepared. We've got a team ready to assist with swabbing, and obviously we would assist with the management of the outbreak. So one of the areas that has had a bit of publicity this week is areas for increased testing. And in Sydney LHD, we have 2 areas at the moment that we are advocating for increased testing of people who are symptomatic, not people who are asymptomatic. Those areas are the Inner West local government area and the Canada Bay local government area. And the reasons for that is that over the last week or two, we have seen some of this transmission where we don't know about a source, and we are concerned that there's some community transmission going on. So we really want people with respiratory symptoms to either go to their general practitioner or one of our sites for testing, so we can identify cases and put them into isolation if they test positive. So we have some testing sites. You may be aware that we had the first COVID clinic, the coronavirus clinic. Subsequently, they're everywhere now, and obviously there's private and public facilities now to do testing, and testing is really the cornerstone now of our public health response. We've got clinics at RPA Concord, Canterbury and Balmain Hospital. We also have a drive-through at Summerhill that was initially available for staff, but it's now available for members of the public. And we're hoping to open some other sites next week at Rozelle, 5 Dock and Hurlston Park. And if you're interested, if you need to refer people or if you need to attend yourself, the addresses and opening times are on our Sydney LHD website. We also have a number that people can call for results. If they're negative, they're given their results. I've given the hotline number there, and that's if they have been tested in one of our sites. With positive results, if we get a positive result, as I said, they often come late at night. Our public health unit will contact the patient first. That's an unusual circumstance, but we're very keen to contact patients immediately to make sure they are in quarantine and find out who their close contacts are. But what we do ask patients to do is to call their GP the next morning and let them know that they've had a positive test. And the result does go immediately into My Health record, and we're hoping that the laboratories will have a procedure by which they can get information to the GPs as soon as possible. I know this has been a bit of a tricky area, but what we are relying on is people giving us their GP contact details in order for that information to be able to be provided. One of the things that GPs can do if one of their patients has had a test is call this 1-800 number, and if the GP is nominated on our records or on their registration papers, we can certainly give that result to the GP. If it's not nominated, we have a bit of difficulty with that, and then we ask the patient to try and get that information to the GP as soon as possible. I just emphasise that our testing sites are only for diagnosis. They're not for clearance swabs for healthcare workers or residential aged care workers. I just mentioned a few other things because we're asked about this quite a bit. First of all, in terms of strategy, it's not clear where Australia is going. There's a lot of discussion about whether we go to an elimination strategy as per New Zealand, or a suppression strategy, which is essentially what we're doing now, or a situation that, for example, in Sweden, where they're actually not doing lockdown. So it's not clear where we're going. An important issue for us is schools reopening, and I think public health people generally really strongly support this, because we can see this is going to go on for a while, and we know that schools are really important, especially for our disadvantaged kids. So we will be having a process to manage any cases that we identify in schools. And the only other thing I'd mention is that there is no need in current guidelines for clearance swabs for people unless they're healthcare workers or residential aged care workers in sensitive occupations. So I think I've done my 10 minutes, but I'm very happy, the Public Health Unit, we're always happy to take questions from GPs, and thanks for listening to me.
Thanks, Lena. We've got time for a couple of questions. I think one question that we've got was just people are asking, do patients need a referral from their GP for the drive-through service?
No, they don't.
Okay, great. And look, and I think it's good to hear that the results are going to hopefully be better communicated to GPs, because that's one of the issues we're frequently hearing is patients are turning up at GP practices and say, oh, I had a result 3 or 4 weeks ago, but the GPs are not aware that they've been tested or that they've been under anyone's care. So that's good to hear. Thanks so much.
Thank you.
Thanks. Our next speaker I'll pass over is Dr. Vicky Shepherd. As I mentioned, Vicky's Deputy Director of Southeast Sydney Local Health District, to provide an update from that area. Thanks a lot, Vicky.
No worries. Good evening, everyone. And if I can just have the share the screen control. Is that up? No.
Not yet.
Screen. Show my screen. Okay. Okay. All right. Good evening, everyone. So we have 2 local health districts, and so slightly different approaches. The situation in CESPHN differs a little from Sydney. So we have had the highest case counts and the highest population rates of COVID in New South Wales. And we've also got the highest testing rates per head of population in New South Wales. So we're very pleased about that, because as Lena was saying, it's really important that we are finding as many cases as possible through a lot of testing. In CESPHN, we're rolling out a virtual care package for high-risk patients, and our facilities are well placed to accept COVID cases at the moment. And similarly to Sydney, we've done a lot of planning with our geriatric and aged care stream to support our aged care facilities. So this is the epidemic curve for CESPHN, and similarly to the statewide picture, we peaked in late March. The red parts of the bars are the people who are contacts of a case, so that's okay. There's largely household contacts or known contacts. And the dark blue sections of the bars are the people who don't have a contact identified. And you can see that was particularly a problem in late March and early April, whereas now we're getting fewer and fewer of those contact not identified cases. So that's reassuring that we're able to find out the source of most people's infection, but you know, we would like it to be 100% where we could identify that source. This shows the confirmed cases by notification date as of 8 o'clock last night, according to the local government areas in southeastern Sydney. So in the past week, we've had very few cases, only 13, whereas up at the peak of the epidemic, we were getting 40 cases a day. So we're very thankful those numbers have dropped off. But on the right hand of that table, we see the crude rate per 100,000, and that's where really Waverley and Woollahra show up as the hotspots for CESPHN, and to a lesser extent Randwick and Sutherland. We've had 2 deaths of our residents, both people 80 years of age or older. And our recovery data shows that 96% of people who were diagnosed more than 21 days ago have already recovered. So that's also looking very promising. This shows that data in the previous table by postcode, so very much showing up the Waverley and Randwick, Maroubra postcode areas as the most frequent places of notification in the past 15 days. This is the age and sex distribution of cases in CESPHN, and very similar to the statewide and national patterns, with peaks in those aged 20 to 40 years of age, and fairly evenly distributed between males and females, with a slight predominance in females. So perhaps the usual testing bias that we do see amongst females. This is the testing data for residents of CESPHN. So the numbers of tests done each day. So we're pretty stable at the moment at around 500 per day. And the red line is the positivity rates, which has fluctuated over time, but was certainly very high in March. And now you can see it's less than 1% of people tested have a positive COVID test. So that's all looking very promising. As far as our testing sites, this is a map and obviously showing also neighbouring testing sites that may be relevant. But we've got obviously the main public hospitals, Prince of Wales, St George and Sutherland, but also Sydney Children's Hospital have a testing clinic, Sydney Eye Hospital and St Vincent's. Then we also have, well, the Bondi Junction one there is the PHN clinic. The Bondi pop-up is drive-through and walk-in at Bondi Pavilion run by St Vincent's. And we also have the Kirkton Road outreach bus, which is visiting a number of homeless hotspots each day. And our Hurstville clinic, which is also able to offer outreach testing, so could test in the home of persons unable to leave the home, disabled, etc., if necessary. Different to the situation in Sydney, so on top of these testing clinics, we've also got virtual monitoring clinics in the all the testing clinics then link into a monitoring clinic, and they will also do clearance testing for healthcare workers and aged care workers. In the next week, they will be rolling out remote oximetry and heart rate app, and that's for people in the high risk clinical categories that you see there, so high risk either clinically or socially. So those hospital COVID clinics will monitor those people, and they are hoping to refer low risk cases back to their GPs for telehealth monitoring. So I think that's pretty much all that I wanted to go through this evening.
Great, thanks, Vicky. We've got time for a couple of questions still. I just wanted to check, so with all those multiple clinics, we're going to come on a little bit later to talk about respiratory clinics versus the COVID screening clinics. From your perspective, do you see them have different roles?
Yeah, in our district, and of course this has evolved very rapidly, but while they may be located at the same facility, they are tending to have different teams that are running the testing, and a separate team that will, of usually respiratory physicians or sometimes ID, that are doing the follow-up through the telehealth or virtual care clinics. They of course work closely together because the testing team passes on the positive results to the monitoring team.
Great, and thanks, Vicky. And then we've got Michael Bonning, who's a GP and a medical director of one of the respiratory clinics later, so he's joining in our panel discussion. And then just one other question, and this is just what happens if we pick up a private case. So if we were to randomly do a private pathology test, what would happen?
Yeah, so the process in Southeastern Sydney will be that that will also be notified to the public health unit, and as part of our assessment of that person, we will have a discussion with the GP and assess if the patient is low or high risk. If they're high risk, we would offer referral to the COVID monitoring team in the local facility. If they're low risk, then we'd be hoping the GP would be doing clinical monitoring. And I think that the health pathway that we're going to talk about will really support GPs to do that from now on.
Great, thanks, Vicky. And that's a great segue to our next speaker, who's Dr. Martina Gleeson. So Martina's going to talk about health pathways and perhaps provide us, with a bit better of understanding of which facilities are for which purposes. And Martina's the clinical lead for general practice for Southeast Sydney Health Pathways and a GP at Caringbah Family Practice. I'm just going to talk about the health pathways and monitoring of people diagnosed with COVID in the community.
Thanks,
Hi,
Michael.
Martina.
How are you going?
Good.
Right, so let's hope that this works. Can everyone see my screen? Hopefully you can. So
Yep.
I'd like to introduce you to the Health Pathways projects. For people that don't know what Health Pathways are, they're locally developed clinical guidelines that are developed in cooperation with our local subject matter experts. And because CESPHN has 2 different local health districts, we have 2 different health pathways team. So I'm giving you the login and the where to find the Southeastern Sydney Health Pathways team, which I'm involved with, and this is also the Sydney Health Pathways login with your username and your password. So when you come to Health Pathways and you log in, this is what it looks like. And sorry, I hope you can still see me. Looks like that's better. One of the things that's different about the COVID-19 pathways is that probably for the first time, all of the health pathways teams in our region of New South Wales have cooperated so that we have unified message, and we're very grateful to the Hunter New England team who have taken responsibility for engaging with the Ministry of Health and developing the pathways. And we have a person in the Ministry of Health who's informing the clinical editor at Hunter New England about changes about to come each night, so that by the morning our health pathways have all been updated to be the most up-to-date, and sometimes the changes are ahead of the New South Wales Health site, which is, so if you ever see a difference, that's probably explanation. There's a few different pathways there for COVID-19 that we have live at the moment, starting from practice management, which gives you information on how to manage your practice and suggestions for how you can limit the risk of infection to your patients and to your staff. The GREAT pathway, the initial assessment and management pathway, which has been up since the middle of March, still gets updated regularly, takes you through the process of assessing and managing, and then we'll also give you connections to where you can organise assessments. So here's the request page, which will first, if you're somebody who's very unwell, gives you the phone numbers to emergency to send them to hospital, but also talks about the GP respiratory clinics and the screening clinics and gives you links to all of those. There's also a recent changes pathway, and we've put this here so that if you're familiar with the pathways and you read them 2 days ago and you just want to know if anything's changed, if you check onto the recent changes pathway, you can have a quick look at that initial assessment management pathway and see that actually something was changed today, and it actually tells you what that change is. So rather than having to read the whole pathway, if you're familiar with it, you can just have a look at those changes. The telehealth pathway has recently been uploaded, probably in the last week, and is continually being changed as the telehealth picture changes. But that's also a very helpful pathway. Sydney has been doing a fantastic job. They've got all those same pathways that I just showed you on the Southeastern Sydney pathway, but couple of other pathways that are really helpful. One is the impact on local services, and they've actually got information about all of those areas of practice and how that might affect your referral pathways, for example, into hospital-based services, so that you can check on that pathway to see if you're likely to be able to get an appointment for your patient and how you might be able to manage that. The pathway that Vicky mentioned it's in draft at the moment, so I'm showing you my draft site because it's not quite ready to be released, but it should be released within the next few days. We just need to get sign off and some of the information about that COVID telemonitoring team that Vicky mentioned. But this pathway is going to be, the ongoing assessment and management pathway is going to be for what to do with a patient who has been diagnosed with COVID-19 and who is suitable, how to identify the patient that needs to be managed by the hospital services, and how to manage a patient who is actually suitable for GP care, and the suggestions for how to monitor them. So this is a pathway, again, that's actually been developed worldwide, but obviously everyone's going to have a slightly different approach in their area, and so we've been working on work that's been done by other teams in other parts of the world, but we've worked with Vicky to make sure that it represents what's actually happening in the Southeastern Sydney area. I just wanted to let you know a couple of other ones that are to come, and we're working on pathways on managing patients in residential aged care facilities, COVID-19 in older persons in the community. We'll be working on one on the management of COVID-19 in children, and there's another one coming for end-of-life care for people who choose not to go into the hospital and stay in the community. And there may be one coming on e-prescribing, but that will be towards the end of May when we finally have e-prescribing available to us. I would also ask people who are using health pathways to use the feedback buttons if you find anything that doesn't make sense, or if you find it helpful. And there's also a button on all of the health pathways sites for you to request a pathway if you can't find what you're looking for. And Michael, that's my presentation today.
Thank you so much, Martina. Can I just ask, one question people have had is, can we just see those logins again? Just so.
I'm really happy to share them. So that's Sydney, and that QR code, if you just throw your phone up in camera mode, it'll take you straight to that website. And but if you take a photo of it, then you've got your username and your password. And I'll just give that a few more seconds for people to get organised. And that's Southeast Sydney one.
Great. While that's there, can I just ask you one question in terms
Sure.
of the GP respiratory clinics? I think there's a bit of confusion about who would be the appropriate people to send to the COVID clinic, who would the people you'd send to the GP respiratory clinic. Does Health Pathways sort of outline that clearly on who you would ideally send where?
It is in the process of making it clearer. At the moment, the respiratory clinics are listed under their own listing, under assessment, and we've taken the description of the clinic from the clinic's own description, but we are in the process of reorganising the request page to make it much more clear about, so we're doing testing in one part and the respiratory clinics in the assessment part, so hopefully that will make it clearer to doctors. And then we'll also be putting in the local health district telehealth monitoring monitoring team in their own separate entry so that they can be more easily found by doctors who are managing patients who have got a positive diagnosis.
No, great job in sort of collating all this information and getting it up and available for us. So thanks, Martina.
Thanks.
Now we're running a little bit ahead of time, but I always think that's a good thing. So I will move on to our next speaker, who's Dr. Amandeep Hansra. Amandeep's a general practitioner at Bondi Doctors, and she's a leader in digital health in Australia, providing digital health consulting services across the health sector. And most recently was the CEO and medical director of Telstra's telemedicine business, ReadyCare. And she's very experienced in talking about telemedicine and telehealth. And what she's going to do is hopefully give us a bit of background. I think today I heard we're at the 6th wave of MBS telehealth item number amendments in the last week. Hopefully Amandeep can provide us with some practical guidance on using telehealth in our patients with COVID-19 and potentially beyond. Amandeep, are you there?
I am, Michael. I hope you can all see me. Okay, so I'm just going to share my screen. So just bear with me a second.
Great, that's all there.
Okay, so thank you everybody for joining us tonight. So just check, can you still see my screen? Sorry.
Yes, yep.
Okay. Very interesting system. I must have used about 20 of these over the last couple of weeks. Seems to be there's no shortage of webinar platforms around at the moment. So I just want to talk to you a little bit about telehealth and a bit of an update. I'll cover a few different areas. So Michael, I might actually make up some of that time that we're running ahead in. So apologies if I go over, just tell me to stop. So first of all, I just want to touch on the Medicare changes. So most of you would be across these because you should have already been using them for the last few weeks. So we've got temporary Medicare item numbers that have been in place from the 13th of March, and they will continue until the 30th of September, and at which point they will be reviewed. So the most recent changes, I guess, are more around some of the bulk billing options. So originally people know that when we first got the item numbers, we had to bulk bill everybody, and now the bulk billing sort of rules have changed where for Commonwealth concession card holders, children under 16 and vulnerable patients, we have to continue to bulk bill. But for other patients, for GPs, we are allowed to apply our normal billing practices. Now, for those of you who are unsure about who comes under vulnerable, that is a lot of patients. So any patient that's required to self-isolate or self-quarantine in accordance with the AHPPC rules would come under the bulk billing sort of mandate. Any patient that is over 70 years of age, if they're identified as Aboriginal or Torres Strait Islander and over 50, they're pregnant, if they're a parent of a child aged under 12 months, they're being treated for a chronic health condition or are immunocompromised, or meet what they call the National Triage Protocol criteria, which is really what's under, if you go back to AHPPC, the sort of patients that fall under a suspected case. A chronic health condition is anything that a patient has had for at least 6 months or is likely to be present for at least 6 months. And I think that's sort of a bit of a grey area where people have really struggled around whether patients fall under that category or not. And I think if you're in doubt, it's safer to bulk bill those patients. As of the 20th of April, specialists and allied health practitioners are not required to bulk bill, even those patients in the vulnerable categories. So there is a little bit of a change between what specialists can do and what GPs and other medical practitioners can do. The bulk billing incentive has been doubled, and there's 2 new bulk billing incentive item numbers that have been introduced for those vulnerable patients that don't meet our original bulk billing incentive item numbers. So again, all of that information is available on the Medicare Online service. It's important for people to realise that the telehealth item numbers cover audio and cover video consultations. So you have to connect with the patient in one channel or the other, and the item numbers are different depending on whether it's video or audio. They pay the same, but you do have to have one or the other. And it does not include asynchronous channels. And I have had some people who've been having chat conversations with their patients, and that doesn't count. So if you're using WhatsApp or Messenger, you actually have to connect with the patient through an audio or a video link. The rebates are paid at 85% of the new item fees, but it has the item number has been raised, so that's equal to what a face-to-face visit, what you would get for a face-to-face visit. Other questions that I've had from people are whether you can use the telehealth item numbers multiple times a day. You can, but you must document the time and the reason, and it can't just be a continuation of the same consultation. And that's the same with a telehealth face-to-face, a telehealth and a face-to-face in the same day. So again, you are allowed to bill those twice in the same day, but you have to again have a reason for that and document that clearly. We will talk a little bit about some of the logistical issues. Again, it can be quite complex in trying to get certain things like scripts and medical certificates. There are some things that you can get away without a signature, so pathology and diagnostic imaging request forms. Unfortunately, scripts, we still do need that signature, and medical certificates, usually the employers will want a signature on it, which then does require the extra logistical challenge of printing things and signing them, but we'll mention that in a little while. So video platforms, again, this is a question that's come up a lot in some of the discussions I've had with GPs, what platforms to use. The department has recommended not to use free platforms, and if you are looking at some of those free platform options, you really do need to check that they meet the Australian privacy principles and all the data security and privacy sort of rules in Australia. And that's things like making sure that your consultation is encrypted end to end, that the data is hosted in Australia and not overseas. Some of the other countries, I know in the UK, have relaxed some of the rules around this just because of the crisis at the moment. But my advice is, if you can, a paid platform is a better option. And there are platforms out there that are healthcare specific. And at the moment, there's been sort of an influx of products coming into the market, and it can be quite confusing as to what's a good platform to use. Some of the resources that I've come across myself, the Centre for Online Health from the University of Queensland does have some resources around this. I'll just go to the next slide. So they've actually compared some of the platforms, and this isn't, sort of a very thorough comparison of the various platforms, but what it does do is it gives you an option, it gives you sort of an idea of the things down the side of what you need to consider. So what's the cost, what's the patient experience like, does it have a waiting room feature, what sort of other compatibility issues do you need to think about. Some of the video platforms will only work on Chrome or Firefox, so you just want to make the experience as good for your patients as possible. Privacy and security, again, these three platforms are all Australian based, but some of the overseas ones you may want to look into that into a little bit more detail. Some of the platforms have billing integrated, which is now becoming more important, that we're not just doing bulk billing. Things like minimum bandwidth and help and support. So it's worth having a look at some of these resources, just so when you are doing your comparison of some of the platforms we talked about earlier, that you've considered all of those things, because it's not just your end, it's also it's also oh
thanks, Sam. Yeah,
sorry about that.
Just a little bit of the you got it. Thanks a lot.
Okay, all right. So just be considerate about your patients on the other end and what they need to do to be able to enter the consultation. But having said this all about video platforms, I just want people to be aware that the majority of consultations so far, and we're close to 4 million or so at the moment, telehealth consultations over the past month, most of those have been occurring by phone. So a lot of GPs are sticking to the phones, and that's fine if you feel comfortable with that. It's more so if you want that added video functionality, that these are some of the considerations. And again, the Centre for Online Health has got a guide for health professionals, which talks about your video quality, audio quality, the environment and sort of internet connection. I won't go through all of that because I think it's something that you can have a look at, and happy to share these resources. I just want to mention something about prescriptions. With the scripts, most of you will know that electronic prescribing is on its way, but in the meantime, some of the rules around what we do with scripts have sort of been relaxed. You can send scripts to a patient's pharmacy, a picture of a script via text or email, or you can still fax them. Then it's a good idea to hold on to the original for 2 years if you're not going to be posting the original to the pharmacy. It's a good idea to choose pharmacies that deliver if possible, just again to keep the patients out of the pharmacies because they themselves have concerns about exposure. And if your patient has respiratory symptoms, don't tell them to just walk into a pharmacy. Just make sure they call ahead so the pharmacist can come out to the car, or the patient is able to have their medication delivered. And for pharmacists have requested that we do send scripts straight to pharmacies if possible, rather than to the patient and then the patient sending it to the pharmacy. So electronic prescribing, so what is it? So it's basically a system that allows an electronic script to be transmitted direct from your patient management system up to a script exchange in an encrypted format. And what the patient ends up receiving is a small token via SMS, email, or they can still get a paper printout, and they use this to collect their script. So it basically unlocks the script information for that patient. That token is a unique code, which is similar to the QR code that Martina showed us for accessing health pathways. So from a practice level, it's just really important to check that you've activated ETP. So, you know, that's something that you have a discussion with your existing patient management system vendor. So as soon as that is turned on at the end of May, that you are ready to go, because I think that will just make life so much easier for a lot of us. I won't go through this, but this is basically just a workflow that sort of talks about how you've got a patient who's vulnerable, who doesn't end up having to leave the house at all if we're using electronic prescribing, because they can receive the token and the token sent directly to their pharmacist, and the pharmacist can deliver that medication to the patient's home. So just in terms of actually conducting the consultation, it's always a good idea to sort of have a bit of a checklist of how you're going to do this. So making sure that you have everything set up, whether you're at home or whether you're in the practice, and you can access those item numbers whether you're working from home or working from the practice, just using the same provider number. So check first, are you going to be doing a video call with the patient, or are you going to do a phone call with the patient? And you might need different things, you know, obviously depending on what you've got, what kind of consultation you're having. Make sure you've got a private space to conduct the consult in, and I'd always recommend testing your technology beforehand, which is sort of 101, but a number of people that forget, and then it eats into the first consultation that you're trying to do. Once you're on a run, you seem to go okay, but it's just, first of all, making sure that you can access the clinical records if you're working from home, and making sure that somebody can see you and hear you if you're doing video as well. Always have the patient's phone number with you in case a video doesn't work and you need to default back to a phone call. And we talked about having access to their record. Again, just having a bit of a flow of how you're going to do the consultation. So making sure that you're checking their identity when you first speak to the patient, they're stable, they're comfortable to continue the call. You do need to get their consent to the consult happening in the manner that you're doing it, whether it's a video or a phone call, and that they agree to assign the patient rebate to you if you're bulk billing. And then it's basically like any other consult, taking a history, an examination, and giving them a plan at the end, but also a little bit about safety netting, which we're going to just talk about. The NHS in UK has some great resources. So this is from the British Journal of GP Life. Again, I can give some of these resources to you, but just goes through how to get your practice set up, how to do a high quality consultation, and also information for patients who are consulting by video, because part of this process is also making sure that your patients have access to information about what they need to do on their end, because it's a big change process for them. So this is an example of the way I end up setting my system up. So having my patient management system open on one side, my video on the other, and getting my patient to do all sorts of interesting things while I'm trying to examine them. So if we look at a workflow for general practice, again, this is from the NHS, who have given us lots of resources, and I think it's great that they're a little bit ahead of us in some of these things. So the practice that I work at, we do this process where our patients can only book a telehealth appointment with us at the moment. So every single patient has that first, and we do that by choice, telephone or video, whatever the patient prefers. And we do the assessment and basically work out whether that's a patient that we can sort out via telehealth or whether we need to bring them into the practice. And if we are bringing them into the practice, we make sure that the risks have been mitigated, and whether that's through PPE or bringing them in when there's other patients you know, who are all well at the same time, so all for flu vaccinations or all for antenatal appointments, etc. Now, some of the questions I've had around examination over phone and video, and you know, this is probably the most challenging part about doing teleconsultations, is that how do you examine a patient when you can't physically touch them and you can't use any of your tools? And I'm saying that you're never going to replicate what you can do in person. I mean, it's a compromise, but you have to weigh up the benefits versus the risks of having that patient in your practice. So use your clinical judgment, and you know, there are things that you can try and get the patient to do, whether they're a parent or whether they've got a carer or somebody with them, or you can ask the patient to do themselves. This is just an example of some of the ways that you can get them to do things like respiratory rate. Again, it'll never be as good as what you do yourself, but it's starting to give you a little bit more information than just that your history taking, which again is going to be a little bit more thorough because you don't have that ability to just eyeball the patient. I always listen for other sounds that I can hear, you know, in the room, especially if you're doing a phone consult. And if you're video, it's really important to look around and see what's around, because sometimes getting information from the environment can really assist you and understanding how much, you know, the patient is affected, or, you know, what sort of environment they're living in. When I used to work for a telemedicine company before, we had guidelines that we used to use for examination, and there were things that we could get the patient to do, you know, to try and examine. So for example, if we're looking at their throat, getting them to open their mouth, put a mirror in front of them and get them to describe what they can see. You might get them to cough into the phone so you can hear the cough, or you might get, you know, the patient or the parent to describe what the breath sounds sound like. Again, it's never going to be as good as you doing it, but it's, again, giving you that little bit of information. So with COVID-19, most patients can be managed remotely by self-isolating and treating their symptoms, but it's really important, especially if you're the GP that's taken on that responsibility, that you do continue to monitor the patient. And this is where the health pathways comes in handy, and Martina was showing us that there's that section there on how to do sort of monitoring of a patient in the community. They do deteriorate usually in week 2, and that's often sometimes, you know, a time when they sort of get forgotten as, you know, other things are going on. Shortness of breath obviously is one of the most critical things that you need to assess, and that's, you know, the symptom that can deteriorate over that second week. And that's difficult to assess remotely, especially on the phone. There has been a lot of talk about Roth score, and I don't know if people are aware of Roth score, but there has been, you know, some discussion around using that. It's sort of a breathing, it's a tool that you use where a patient sort of counts while they're breathing, and you assess how far they can count before they have to stop, as a measure of, you know, the correlation between their SATs, if you did their O2 SATs. It's not recommended as an effective tool for COVID-19, as the sort of the latest statement on that. You can use it in conjunction with a whole bunch of other things, but it shouldn't be used alone as a measure of whether a patient's deteriorating or not. Having video for a COVID patient does help, just being able to eyeball the patient, being able to look at any respiratory distress that they have, getting the patient to use what they've got at home. If they've got a thermometer, if they happen to have a peak flow, if they're an asthmatic or something, getting them to use their blood pressure monitor, because you might get your heart rate out of that. Respiratory rate, you can measure over video. You can attempt it over phone call, but again, it's difficult to rely on. And distinguishing things like flu from COVID, it's really about getting a history and working out what symptoms someone has versus, you know, doing the examination. If you're worried the person has developed pneumonia. So, you know, the basic things that you're asking again through telehealth, you know, around temperature, respiratory rate and heart rate. And children obviously have the specific symptoms that you can ask for. The best resource I would advise you to use, and this is available again on the PHN website from the BMJ, is this a visual summary of how you do a telehealth consultation for COVID-19. And the most important thing is really ruling out those red flags. So if you have a patient who has any of those, they are, you know, needing to have medical, physical face-to-face medical assessment pretty urgently. But if you go through that process, and I've printed this out and I have this up on my wall, so when I'm doing any of these sort of COVID assessments, I know exactly what to ask and I know that I'm not missing anything. So this is a great resource, and as I mentioned before, the safety netting part, so making sure that a patient knows when to call back. Again, sometimes I'll sit and wait for your call. You'll say, okay, I'm going to ring you back again tomorrow or the next day. But they must know that if they start to deteriorate or they develop any of these symptoms, that they are to access medical help, and you need to tell them how to do that. Because I think some patients, when they feel like they need to self-isolate, literally shut the door and stay at home and say, okay, I won't go anywhere, I won't call anyone. But they need to be encouraged to get further medical assistance if they do deteriorate. So really just my final tips for telehealth is, you know, electronic prescribing is coming. Use your secure messaging if you have it. If you don't have it, please get it. Don't stress too much about the technology. If all you have is a telephone, then you can still do telehealth and you still get the Medicare item numbers. But there are lots of fancy platforms out there that have integrated payment gateways, bookings, triage tools, but don't feel overwhelmed about that. I think telephone is fine if that's all you have. Just don't use your personal phone, and this goes for Skype IDs, WhatsApp numbers. The last thing you want to do is start having patients calling you all the time on your personal phone number or your personal Skype ID. And I say that from experience because I made that mistake. And always have your clinical notes with you. Don't just wing it. It's really important to be documenting and accessing your patient's past medical history, and be creative with your examination. There's lots of resources, and I will just pass those around if anybody is interested in learning more. And I will stop there.
Maybe leave those up for a couple of minutes while we just got a couple of questions.
Sure.
That was fantastic. Look, thank you. It's good to hear someone who's got some practical experience, and just those tips on how you do different clinical examination tips remotely was really helpful. We've got a couple of questions, which just sort of clarification things. Someone has asked, if you just about the billing. So if you do a phone consult and then get someone in and do a face-to-face, like you, it sounds like you're doing at your practice, can you bill both those item numbers on the same day?
Yeah, so this was a question that was put to, I think, when we had one of those sessions with Professor Michael Kidd. And I think as long as, you know, it's a separate instance and you're seeing that patient, there's a legitimate reason that you need to do a physical assessment and you're documenting all of that, they didn't see a problem with that. I think it was more just they didn't, you know, if you had just a continuation, like you started with a phone call and the patient walked straight in, that might not count. But if you've got a separate instance of it, that you could bill that.
And I suppose sort of the reverse, if you saw a patient and asked them to have some investigations, and then you followed them on the phone via a video or telephone consultation later in the day, can you bill both of those?
Yes, and it'll be the same with you monitoring a patient. So if you saw them for a COVID-related, you know, assessment, and then you decided to check on them every day, those are monitoring consultations as you would be monitoring any other medical condition. So I think those, you know, it's what sort of the system is designed for us to be able to do.
That's great. Thanks for clarifying that. And just two other quicker ones. Someone's asked about a platform called GP Consult Platform. I don't know if you're familiar with that one. It's a free platform. Are you familiar with that one?
Yes, I have come across them. Yeah, there's so many out there, and it's really difficult to sort of navigate your way through if you're doing this quite quickly and you're quite new to it. My advice to you is to try and find something that at least integrates with some of your existing systems, because the hardest thing is when you've got multiple things open, and you'll probably realize this when you're trying to do video consults and you've got your patient management system, have health pathways open, you might have your therapeutic guidelines, you've just got too many systems open. So I actually have multiple screens on my desk. So if there's a way that you can integrate some of those platforms, that's probably the best way to go, so that you can just click one link and it takes you to your video platform. So I don't know that one in a lot of detail, but I think if that integrates with some of your other systems, then that's a great system to use.
Right, so it's not about a particular one, it's just about using the technology.
No. It's a technology workflow, yeah.
Sorry, one final question, just asking about encrypted email. Does that have to be based in Australia? Do you know if there's any sort of limitations on that, like the telehealth supposed to be Australian based? Whether the email...
Yeah, so look, I think it's again just about working out if there's any data that's hosted overseas. So when you're looking into any of your digital health sort of products, it's always asking the question about where is data hosted, if it is hosted somewhere and there's data being sort of stored somewhere. So as long as it's not being stored, it's okay to use products that may not be Australian, but if it is traversing other countries, then we start considering that we're breaching some of those Australian privacy principles.
Great, thanks so much, Amanda. And I know you're staying for the panel session, so there will be a few more questions there. Thanks a lot.
Thank you.
And our next speaker is Margie Evans. So Margie's an infection prevention and control clinical nurse consultant at Southeastern Sydney Local Health District. We've had a lot of questions about not just the availability of PPE, which we'll come to soon, but also some people asking guidance about how to appropriately use PPE. So Margie's going to give us a demonstration. Now you're on mute there. Yeah. Still mute. One minute. We're dialing in again. And look, thank you everyone for putting in your questions. We're collating them, and a lot of them will be coming up in the Q&A panel session soon. Yes, the access code.
Can you hear me? No?
Yeah, just go on.
Okay. So for COVID, we're meant to be doing both droplet and contact precautions. So one of the first things when we're doing PPE, you should be bare below the elbow. Jewellery should be removed, rings, because there's no way of really cleaning your watches and you're going to take the bugs back on that. You commence always with a good hand hygiene. And you've got this locked as well. You make sure you get under the nails, make sure you don't miss your cuticles, and you've got to keep rubbing, making sure you miss no part of your hand. If you miss any part of your hand, when you touch your face or whatever, it goes near that. Making sure when you do your thumbs, you go from the wrist right up to the nails to make sure that's not missed, and to the nails to make sure it's not missed, and don't forget your wrist. And that's the one that, if you've got watches on, it prevents you doing the good hand hygiene. You have to keep rubbing it until it's absolutely gone, dried, and it disappears with drying. You put your gown on first. And when you put the back on, you need to cross it over just to cover all your clothing. And just tie at the back. No gown should be tied at the front, because if you're tied at the front, and some have got quite wide ties on them, it means that you're going to just collect more, like they're big ladles, to collect all the bacteria and viruses in, so you contaminate it when you're removing it. So that goes on first. Then your mask. Now, with the mask, just bend the metal a little bit. If you wear glasses, or even when you put your protective glasses on, if you don't fit your mask properly, it fogs up badly, as well as it's not going to cover you. You only need a surgical mask. Put it on. So just making sure it's there and mould it down into the gully, but don't have it too high that it's going to go up above your glasses. Putting your glasses on, and to make sure that you put your protective glasses over that to give you the protection you need. Lastly, the gloves. Gloves should be covering the cuffs of your face, and you're quite well now covered for whatever you need to do. If you have to be within 1 metre of the patient, particularly if they've got COVID, have this on, but make sure you have your mask and your eyewear on. Don't forget your eyewear. Removing it is a bit more tricky. Until SARS-1, we never taught people how to doff. And it was during SARS-1 that we realised that people actually got contaminated and they actually got the disease with that. So it's important doffing that we do it very slowly and carefully. That you make sure when you do it, you go from dirty to dirty. Don't put your dirty thumb underneath your wrist. You just get the dirty to dirty of your gloves. You roll it down carefully, confine and contain into your other hand. Don't put your clean thumb on top of your gloves or that. Just put it underneath. You're safe. Only touch the part that's touched you. Roll it over, confine and contain into the bin. It is in removing gloves, research shows us that 30% of us get contaminated in doing that. So you make sure every time you remove the glove, it's not a substitute for hand hygiene. You have to do your hand hygiene absolutely again to make sure you're killing any of those bugs. And you particularly do it any time you put your hands up near your eyes, so nothing falls from your eyes, nose, mouth into that. I can either take off my eyewear now, because they're a bit loose. I would do that on this one. My hands are clean, so I'm happy to take that off. Because it's reusable, and even if we don't have enough, most of these can be clean, so I don't mind if we reuse them. Wipe them over initially and put them down and let them dry, but you can wash them at the end of your shift. And if they are the single-use ones that you have to reuse, make sure you keep it to that one person. They're always using their own, and reuse that. And I'm doing the back, the front of the back, and the front. Now remember, all the outside of this is contaminated, so I don't want to touch any of this. You only touch the inside because you know you're safe. Over your shoulder, and you turn it in, even these parts out there. So you only want all of that that's been next to you to be on the outside because you know you're safe. And so all that now, I just roll that up into a ball, and I know I'm only touching parts that touch me. Because that can be contaminated and I'm going to put my hands in my face again, remember it can come off, anything under my nails and my hands, I'm going to be just cleaning my hands before I put them safe. You can only ever touch your strings, but don't put your head in because all what's on the front of your mask will fall down in your clothes. You lean over just a little bit, chin out, holding it by strings only and into the waist. And that's the last. If you've got any, it's quite simple. Just do it slowly, carefully. Remember, doffing's the most important. Thanks. Any questions?
That was great, Margie. It's one of those things I think now I know how to do it from an expert. So thank you very much. Look, one of the challenges I think that some GPs have been having is we've been doing screening clinics and don't think we've got enough gowns to use for a different one for every patient, and particularly if they're low risk ones. Do you have any comments on that? We're going to come to that in our panel. but
I don't believe you need to change it every patient, and if you do, you often rush it and you often get contaminated. You're not, unless a patient's touching you or something like that, no one's getting contaminated, or unless it's contaminated. I don't mind if you do it at the beginning of the, whatever you call a list, put your PPE on and remove it, except for your gloves, keep changing those, or just do hand hygiene, but you don't have to change the gown until the end of the list. Whichever your list is, that might be for your cup of tea break or something like that. There's no problem in leaving your mask and glasses on. Yeah, it's really quite fine, and particularly while it's limited, you can plan it and do it quite well, but if you rush it and want to change it every time, I see no gain. You haven't touched it, the patient hasn't touched it, so there's no problem with it.
that's great. I mean, I've been doing some screening, and in my practice, it's if a patient doesn't cough or sneeze and they're otherwise, there's nothing coming on me, being felt confident to reuse that gown. So that's good to hear.
Yeah, it's just risk assess both your procedure and your patient in always what you're doing, and it's not a problem.
Great. Look, thank you so much, Margie. We've had a comment from the group saying fabulous PPE description, so thank you very much.
You're welcome.
Now, our final speaker, sorry, I'll come back up. Our final speaker is Dr. Brendan Goodger. Brendan's the General Manager for Primary Care Improvement at Central and Eastern Sydney PHN, and he's just going to outline some of the CESPHN support and resources, and he'll be our final speaker before we move on to our panel discussion. Brendan. On mute, sorry. Yep, you're right.
Just really want to give you all a bit of an update from when I spoke to you last about 4 or 5 weeks ago now. Things have changed a lot in the last 4 to 5 weeks. We've now had telehealth that's now been deployed. Our digital health team have been flat out calling up over 400 odd practices and really trying to say to them, these are the arrangements around telehealth, trying to support them in terms of their implementation of that, and also promoting the Health Direct video tool. There's a trial now that we have signed up for. That trial goes into, I think, June or July. We hope that it will be extended beyond that. And that's a free, if you like, telehealth platform that's available for practices. And again, if you're interested in signing up for that and getting some support from us, then just send an email through to telehealth@cesphn.com.au, and one of our digital health team will be in touch with you. I think the other really key thing around telehealth to know is the huge uptake has been really quick. We've had nearly 50% of practice consultations are now being conducted by telehealth. And I think what's also interesting too is nearly all of our practices in the region are actually doing telehealth. And they're also telling us in these 400 odd phone calls that we've made, and we've got more to do as well, that life has changed, that they're now committing to telehealth, and that they do see telehealth as being a key area of work beyond COVID, knowing that these telehealth items are due to end on the 30th of September. But nonetheless, I think general practice is now embracing this, and they're seeing a future beyond that 30th of September for telehealth. The other key area that we've been working on, particularly in the last couple of weeks, is around immunisation, flu vaccinations. And the Commonwealth indicated to us last Tuesday that they'd like us to be involved in doing a bit of a needs analysis of the 160 residential aged care facilities in our region. So we've been calling these in the last 3 or 4 days and really trying to get a sense of how many residents have been vaccinated, and importantly, or just as importantly, how many staff have been vaccinated. And so of those 160 odd residential aged care facilities, nearly about 62 RSCFs are saying to us, well, we've got over 3,000 staff who require flu vaccinations, okay? So over 3,000 staff who are requiring those flu vaccinations, and then just over 500 residents who are requiring some support flu vaccinations. And I guess the reason why the Commonwealth wanted us to do this for is because we do know that there have been some shortages of the vaccine, and some RACFs have had difficulties trying to access that. And at the same time, the Commonwealth has had the requirement that RACFs will have their staff and their residents vaccinated by the 1st of May. So what they've done is they've called the PHNs in to try and do a bit of a needs assessment. We've done that, and our next role now is to try and facilitate access to those vaccines, either through the state vaccine centre or through other commercial providers. And we'll be trying to do that in the next week or so. And I guess the other thing too that we found out, about 17 or so actually will require assistance with flu vaccination actually doing the jabs. So as you can see, there's been a lot of work done in the last week really to try to support RACFs in the flu vaccinations. The other area that we've been focusing a lot on is around practice viability, particularly when telehealth was introduced nearly a month ago. A large number of practices anecdotally were saying to us, well, we have a lot of concerns around how our practice is going to survive, because COVID obviously changed, the behaviour of patients. Patients decided that, hey, it's risky going to practices, therefore I might self-isolate at home. And so they've changed their health-seeking behaviour. And we'd also heard reports too of practices, reducing the number of hours for administrative staff and for some of their practice support staff. And so what we did was we were keen to investigate this and really try and work out ways in which we can better support general practice. So we did a survey. We surveyed nearly 120 odd general practices, and of that, about 80 odd responded to the survey, which is a great response rate, and it shows a high level of interest in this area. And so what we found was nearly 74% of practices reported that they'd experienced a decline in the number of patients attending. That nearly 35%, actually just over 35%, indicated that it actually reduced staffing hours, both of clinical and also administrative staff. And by clinical, I'm referring also here to practice nurses. It was a concern for us. And a further 20% said that they had experienced a significant decline in income, resulting in the practice running at a financial loss. That's clearly of concern. 65% of practices indicated that they were concerned with their financial situation. And we'd heard anecdotally that some practices had either closed either permanently or were in hibernation while waiting out COVID. Now, what we've also heard anecdotally too, and perhaps these are some questions for the panel perhaps, but we've heard that the flu vaccinations has increased the busyness of practices. So practices are now getting a bit more established perhaps, or being able to respond. We intend to repeat the survey again in about 6 weeks' time, just to see how the issue around practice viability is going. It's an area of concern for us because again, we are concerned about the role of practice nurses. We're really keen to support their role in general practice. In terms of some last concluding comments, I think it's important to note too that people have made mention of the GP respiratory clinics. Myself and my colleague Natalie Hanson, who's silent but online, we've rolled out now 5 GP respiratory clinics through the CESPHN region. There's a bit over 20 on Australia. Well, guess what? We've got 5 of those. There's one in Belmore, one in Lakemba, that's about to start later this week, one in Balmain, one at the Kirkton Road Centre that really deals with the issue of those people who are homeless or living in unsupported accommodation, and of course the clinic at Bondi Junction. And we've been working intensively to get those established, both in terms of establishing but also ongoing support. I'd also say too that we've distributed nearly about 400,000 masks, 350, 400,000 masks, both surgical and P2. And so that's been again a really intensive effort to make sure that general practice has resources that they need to continue assessing patients. Michael, that is a bit of an overview in terms of what we've done over the last 4 weeks or so.
Great, Brendan, that's helpful. I think I think you and Natalie have led the charge in the PHN of dealing with this crisis, and I think you've done an amazing job. The other plug that I would do on your behalf is put a plug up for the CESPHN website.
Yes.
They have been updating all the information on that virtually daily, including information about where the respiratory clinics are, who they're for, that type of information. I'm just a couple of quick questions for you, like sort of hopefully an easy one. Is the PHN still supplying masks, and how do you get masks if you need them?
Yes, certainly we are still supplying masks. We actually have, there's a hot tip for tonight, we actually have a good supply of masks at the moment. So get your in via the order form. We can distribute that to those attendees after tonight. The criteria at the moment is for general practices and pharmacists, and that's the way it's always been. That may be extended at some point, but not at the moment.
Okay, thanks, Brendan. And look, we've got a few other questions about the respiratory clinics, which I think will come up in the panel discussion, but Brendan will be available to answer questions for that. Thank you so much. And we've had a comment, thank you, CESPHN, for your support of nurses and admin staff as well. So, you know, thanks for looking at the whole practice team. So thanks, Brendan. Now, Brendan's the final of our speakers, and we're now going to move on towards our panel discussion, which we've set aside up till 8:30. So what we will now do is gather our panelists together. Coming back to speak on the panel will be Dr. Amandri Hansra, who you've heard before, Dr. Vicky Shepherd from Southeastern Sydney Local Health District, and they're going to be joined by Dr. Michael Bonning. Michael's a GP and he's a medical director of Inner West GP Respiratory Clinic. And they're also being joined by Dr. Owen Hutchings, who is a GP by training and clinical director of RPA Virtual, which you will have heard about early on. And they're also being joined by Dr. Michael Moore, another GP by training, who's CEO of the Central Eastern Sydney Primary Health. I think that's the maximum number of people we can have on a webinar. So I might just sort of jump in with a couple of questions that have come up after your speech, after your presentations. The first one, just for Vicky, that someone was saying, why is there a disparity between numbers of cases and numbers who've recovered? And they said sort of, there seem to be a lot more than the people who've recovered. Is that?
I think you're saying why there's a discrepancy between our total number of cases and those that have recovered. So we're assessing recovery 21 days after onset. So there is a bit of a time lag. So as I showed, when we go back for people who had onset 21 days ago or longer, 96% of those have recovered. There's a very small number who have ongoing symptoms, and of course the 2 deaths for CESPHN. So yeah, the vast majority have recovered. In-depth look at the recovery data shows that it varies by age. So younger people do recover quicker than older people. So yeah, but generally it's quite a high rate.
And Vicky, just one other question with the people getting tested. So if they've tested positive, they've had their quarantine, do they need to, like I'm having patients who are coming in and saying, do I need to get a negative test? And I'm going, why don't we do it here? No, well, that's what I don't know. So, you know, what's
please don't. So there's clinical criteria to release people from isolation, which is at least 10 days from onset and at least 72 hours symptom resolution. Now, the problem with our PCR test is that it's highly sensitive and can detect non-viable virus in the nasopharynx. So what we do find is that if people are tested at that period, a lot of them still come up positive. And that's really, really confusing for everyone, the GP, the patient, public health. So our national guidelines will soon be clarified that irrespective of a PCR test more than 10 days after onset and 72 hours from symptom resolution, we're just going to ignore it. So save the swab, save the reagents, and please don't order recovery testing. The exception to that is healthcare workers, aged care workers, those that are going into sensitive settings. And they do require 2 negative swabs before they can return. but we would prefer to manage those people through the district clinics. But if you do have a healthcare worker or someone working in corrections health or something like that, where they need to get that clearance, then you can order those recovery swabs. So they have to be at least 7 days after onset, at least 24 hours after symptom resolution, and they need two swabs at least 24 hours apart that are negative before they return to work. But if they meet the clinical criteria, they can still leave isolation. It's just that they can't return to work until, or for example, an aged care resident that's in, been in hospital, for us to return them to the facility, we'd have to have those two clear swabs before we did that.
And I suppose you've kind of answered another question which I was going to come up, which is sort of people asking if we're starting to manage, say, mild COVID-19 cases in general practice, when are we able to clear them as such? So the answer is, if it's been 10 days and they're asymptomatic, they're clear? Would that be,
yep,
unless healthcare worker, aged care resident? What about people who've got parents in their 90s? Sorry, that might be.
Yeah. So I think what the new national guidelines are going to say is people going into sensitive settings. So people like that may need a little more reassurance. So what you can certainly do is, if they're 10 days from onset and 72 hours resolved, give them a certificate to say, or a clearance. They can go back to workplace, shops, go into the community. So if there are those more complex situations like visiting highly vulnerable relatives, you may wish to go through that formal swab clearance process. But I must warn you that with the healthcare workers, we're having a lot of trouble. Some of them are having positive swabs up to a month later.
Oh.
So we'd prefer not to do those swabs unless it was, really in those crucial settings.
Great, thank you so much for clarifying those. I know some of them are a little bit greyish, so thanks a lot. Michael Bonning, I might just hand over, just hear from you. So you've involved with the respiratory clinics, but I suppose, can you sort of give us a nutshell to GPs? What should we be sending to the respiratory clinics? What do you do with people there? And how will GPs know that they've encountered your service?
Thanks, Michael, and thanks everyone. The GP respiratory clinics sit alongside general practice. I think in comparison to COVID testing clinics or some of the swab and go services, the drive-through services, we're much more about the assessment of patients, and a normal day today looks like, a couple of people with bronchitis, but with, you need to work out if they have pneumonia. So trying to identify and remove certain differentials. Lots of management of asthma, are things that we've been doing, especially people with, long-term, brittle asthma as well, sent by their GPs. And at the moment, more than 75% of the people using our service come there either on formal referral from their GP or through the pathway that they spoke to their GP and the GP recommended they come down. Now, we exist in that space that is, I suppose, covers mild to moderate illness. And so those people who are quite sick, we operate like a general practice, and therefore it would be very difficult for us to manage some of the more difficult or tricky cases, or people who are severely unwell, they need to go to hospital. The same is true, we don't, because our service specifically, but because we run it's a respiratory clinic, we still need to be seeing people who have an acute respiratory illness. Some of the people we have seen we've talked to over telehealth we've cancelled their appointments because they had a one-day history of symptoms and then when they booked in with us, they were no longer someone who was appropriate to be seen by us. We provide follow-up, so we're using HealthLink and sending follow-up to the GPs who are listed. If a GP is listed and a patient tells us who their GP is. In addition, we are, as much as possible, trying to copy GPs in on test results so that they have a direct record and then a follow-up of some consultation notes and a summary of what's gone on. The last thing I will say, and I suppose I'm preemptively responding to some questions that we've had, which is we're just getting, we've only been going for just over a week, so we're building capacity, which means doing a lot of training with the people that we're working with. And then, so capacity will grow, especially as we get closer and closer to winter. The second part is we do have on-the-day appointments set aside for GPs to call us directly and ask for a patient to be reviewed on the day. We recognise that a lot of the importance of our service is its punctuality and immediacy. Sometimes people do need to be seen that day, and therefore, we're trying to manage for that in the way we set things up.
So Michael, yeah, I mean, there have been concerns raised about people saying they've had to wait days to get an appointment. I suppose two things: do you triage people? Is that would someone have been triaged as being mild and potentially they wouldn't get an appointment, or is it just there is limited capacity at the moment that should improve?
So the capacity is increasing at the moment by about 50% week on week. So we are growing pretty quickly, but it was more a question of delivering sustainable capacity for the GPs in our region, but also in training for safety, so that we can run a safe and effective service. And that requires time and often, multiple individuals being watched going through their processes, and because of that, that takes time to grow. So we do turn some people away because we don't think they fit the criteria of how the service works, and we really do encourage GPs as well, if they have concerns about someone, just to directly call us. I will always endeavour to make sure that someone is seen at a clinically appropriate time frame. But I also recognise that some patients have seen their GP, the GP said go to the service, the patient may have waited 1 or 2 days to see how their symptoms are going, and then they will book in. But to the GP, that looks like they've taken 4 or 5 days to get to us. And we're here to help and to work with GPs to make it happen, or make the service useful for them and their patients.
Two just final clarifying questions. Do you need a referral for that clinic, for the respiratory clinic, a GP referral? And do you wear PPE for examining all the patients?
So first one is, while patients do not need a referral, the way we run the service is we telehealth triage everyone first. In that consultation, we ask people, have they spoken to their GP? We highly recommend between when they potentially would be coming to see us, which is often either later that day or the next day. We're trying to stay ahead of the curve. We ask them to try and book in and talk to their GP, because often their GP will be able to either reassure them or have inherent knowledge of their clinical scenario, and therefore will be able to make better decisions. But people do not need it. They come to us through many sources: Health Direct, the National Coronavirus Hotline, through web traffic from Department of Health. So they do not need a GP referral. The second part is, yes, all of the people assessing patients are in full PPE at all times.
Great, thanks for that, Michael. Hopefully we'll come back soon, but I'll just give everyone a bit of a chance to speak.
Sure.
Owen, I might just pass over to you. Lena spoke to previously about RPA virtual, and it sounds like you've been doing a lot of work with the COVID patients at Sydney Local Health District. Is the burden of patients decreasing? Are you noticing, do you feel like that you've gotten through the worst part of the curve, hopefully?
I would love to be that optimistic, and I think that's true. Certainly, so we've been sort of operating in this space for around about 6 weeks now, and we've certainly seen some spikes in various degrees of activity that the virtual hospital has had to respond to. I'd just like to say before we go on, it's really interesting and really exciting to listen to people talk positively about telehealth. For a large part of the virtual hospital's journey, telehealth has been seen as a sort of step backwards or somehow secondary. So this is the first time I've really heard it talked about in a really positive light. So I'd really like to, support what Dr. Hanshaw was saying about the positivity of that and the steps forward that we can take with this, as Brendan was saying, into general practice and into healthcare in general beyond the COVID space. The activity for us really till now has been in 2 spikes, I guess, and initially that was the response to the need for patients in the hospital coming out into the community, and then obviously the disease progression and potential escalation in the community, and that was how our original model was designed. More recently, you may or may not be aware, but in our district we have a health hotel system that's been developed, where now we're looking after a lot of the returned travellers, a lot of the returned flyers under the gazettes, the public health orders, and now a lot of the disembarking cruise ship crew. So the virtual hospital is also responsible for monitoring those patients in the health hotels under quarantine with nursing support. And we have embedded a remote monitoring program into those health hotels as well as into the community. So we're currently running off a risk stratification protocol that looks at remote oximetry, pulse rate and temperature monitoring. And we're able to risk stratify, but particularly those medium and higher risk patients that might be a little bit beyond the capacity of your general practice, but aren't quite at the level required in terms of hospitalization. And certainly there's all sorts of advantages to keeping COVID patients out of the hospital system as much as we're able to, and not contaminating that system and putting patients and staff at extra risk. One of the very significant benefits we've realized, I think, is the minimizing of contact between healthcare workers and patients, whilst making sure that we're putting appropriate supports and appropriate healthcare networks around those patients. So there's been the virtual hospital with support across the district's done extensive work, putting in adequate allied health support, social work support, psychological supports, mental health supports, as well as the clinical supports that have been required. And the last thing I'd just like to say on that point is that one of the challenges through this pandemic to us so far, and one of the things that's worked really well as a mechanism for us in our district, has been to integrate with the hospital system and have very ready and direct access to COVID specialists, to respiratory specialists, to infectious diseases, particularly for those patients that are deteriorating in the community. And unfortunately, we have had some quite significant and quite dramatic deteriorations that we've required to hospitalize. So it has been a very challenging sphere, very challenging space, but we are finding that some of that pressure is thankfully lifting.
Oh, and can I just ask, Lena sort of alluded before that there's been some challenges with getting test results through to GPs. How are you guys going with how would they know that they've been a patient of RPA virtual? Like, how would I as a GP know that? Or when would I know it, I suppose?
So we've been in quite close discussion with Michael Moore, with Brendan, with the PHN around that, making sure that we're quite clear about communication and notification to general practice. As was mentioned at the beginning, I'm a GP by training myself, so I understand and I hear your challenges, and I can empathise with those. What we're doing at the moment is working on multiple processes. So it's really I know that notification of the disease at diagnosis has been an issue. So we're looking at, we currently have a direct intake from the public health unit to the virtual hospital, and we want to make sure that in real time we're notifying the patient's GP if they have one, so that the GP is really aware at the time of diagnosis and referral as well, because obviously that's invaluable. We want to make sure that the GP is aware of the patients that we do require to look after in the virtual hospital, but also that we're returning the lower risk ones to appropriate monitoring with their GP with the adequate support and systems in place that might be required. It's really then discharge notification, discharge documentation, good instruction around the discharge process and what's required from the GP at that point. And I'd really like to reiterate what Dr. Shepherd said about please don't do swab testing and testing sort of off the guideline or later than the guideline. That has caused a significant amount of difficulty for some of our patients and some of our processes. So we really want to make sure that we're getting the right information out to the GP at the point of discharge. And two things we're currently working on at the moment with the health pathway system is working with our local health pathway writers to make sure that all of our information is properly integrated into the health pathway information, properly disseminated across the system. And then also e-referral processes via health links, so that for those slightly more complex patients that you might be concerned about, that you require a high level of monitoring, you want them to be video conferenced multiple times a day and watched closely with a system that escalates, that you've got that appropriate support and an e-referral mechanism to refer into the virtual hospital rather than defaulting to the emergency department.
Great. Thanks very much, Owen. Amandeep, I've just got a couple of questions. No, thank you very much. A couple of people have been asking whether practice nurses can do telehealth item numbers on a GP's behalf, so things like GPMPs, care plans. Do you know what's allowable and what isn't, or what can you delegate?
Yeah, that's a good question. I would say it's what they're trying to do is mirror what is done in normal general practice as much as possible, so you can continue to do those. As far as I'm aware, the GP management plans are to be billed, or the telehealth equivalents are to be billed by the GP who's done them. There are some item numbers specifically for practice nurses. There's a couple of the item numbers for care for Aboriginal and Torres Strait Islanders and for managing chronic diseases, but not specifically for writing the GP management plan. So I think that still needs to be done by the GP, as far as I'm aware, and the practice nurse is allowed to get involved in those other two item numbers.
Great, thanks for that clarification. I know the PHN's got a guide about the different item numbers too, which they can send out to people, or I don't know if we can add that link to the PHN website. Michael Moore, I might just ask you a couple of questions. I mean, I think we've got these multiple respiratory clinics coming up to try and support, I'm sort of interested how they support general practice. And given that we're talking about these challenges that we're facing with the workforce of, GPs not being busy enough, and where do you see them fitting in with practices and sort of coming into winter?
So I think Michael Bonning kind of covered off on that a little bit. The idea is that these are patients that you would think would be better off being examined somewhere else. So these will be people that have a respiratory illness that you've determined is sufficiently severe that they need a physical examination. So they might have a cough, they might have a high fever, and you're not in a situation, you may not have the room set up for it, you may not have the PPE, you may not be confident in your use of PPE, but you know that this patient needs an examination, you know that they don't need to go to hospital, but they still need to be examined, and they may need antibiotics. And so they're the kind of patients that you would be sending to see Dr. Bonning and his team at Inner West and the other respiratory clinics around the area.
Great, and I think, look, one of the other challenges, I mean, as a GP, I think we're finding that we're focusing so much on the COVID cases that we're having less time to do the chronic disease management. And I suppose the PHN's potentially in a similar area. So much of the PHN's time is spent doing the COVID stuff. How is the PHN managing with, in general and with its other services that we commission? Because I think they're going to become more and more important. A lot of the mental health services and alcohol and other drug services. What's your sense of how they're managing at the moment?
Well, I have to say, I was on holidays for the first 2 weeks of March, and and reading the newspapers and so on. And I came back in the middle of March, and Vicky, your curve was just sort of starting to take off, and every week it got bigger and bigger and bigger. So those you know, last 2 weeks of March were a bit panicky, and so we certainly did have all hands on deck, and, you know, we were looking at how we're going to get all our COVID information out as quickly as possible, and, you know, people were making sure the website was updated every day, and we were getting all our telehealth guidelines in place. I think things are kind of a little bit normalised now. I mean, our staff are mostly working from home now because we're lucky, because we're office-based work, and a lot of the practice visits that our staff do, they do virtually now, so they ring or they go in by video. So we're kind of really, I think, and just in the last week, now that the numbers have kind of come down, there's a general sense now, I think, that there's going to be business as usual under the public health order situation, and that we are going to get back to looking at chronic disease management, looking at our improvement agenda, our integration agenda, and looking at our commission services. So I think the sense that we have is that, yeah, there was a little bit of a disruption, but in terms of how the PHN's operating, I would say we are pretty much going back into a business as usual, but under different circumstances. So what you were saying about, you know, what's happening about GP management plans, what's happening with, you know, chronic disease management and general practice, that's core business for us, and that's something we'll be focusing on. And already we're looking at getting some information out to practices about practices that might be having some downtime, about making use of that downtime to get on top of GP management plans for chronic patients with chronic diseases.
Great, thanks, Michael. I might just sort of open up to a couple of sort of scenarios that have come in as questions. A couple of people have asked now, if as we sort of expand testing and we increase the number that we're testing, and we're potentially, you know, we're looking for people with respiratory symptoms, but who we think are relatively low risk. Once we test them, like whether we test them in our clinic or whether we send them to the respiratory clinic, Michael Bonning, are they then potentially COVID positive? Like, should we then presume that they're COVID positive until they get their result back, or do they remain low risk? Vicky?
Yeah, I'll have a stab at that. Yes, look, I think the principle should be that if someone's tested for COVID, they should be isolated until that test result comes back. We've also got statewide data, and it's a 24-hour turnaround now for everyone, and for a while it's stretched out for a couple of days. So it's a relatively short time, and it's rather regretful if you've tested someone for COVID and let them go about their business and then the result comes back positive. So yeah, we'd certainly encourage isolation even if they seem to be low risk.
Okay. No, sorry.
We'd just like to describe it when we see them as it's essentially their social contract of coming in to get to be assessed and have a swab. And in answering a question there, anyone who meets guidelines who comes through our service does have a COVID swab, and we just say it's part of their social contract. You know, we'll get a result back to them in 24 hours, but they need to be isolated for that period of time. People take it very, very well. They understand the risk.
Okay, thanks for that. And I suppose leading on to that, I mean, as we move into winter and we get more, I suppose it's like the logistics of managing sort of winter coughs and colds, you know, so if, I don't know, 10% of our practice traffic is coughs and colds, are we going to send them all to the respiratory clinics? Like, is that a feasible thing, or are practices going to be, you know, expected to do COVID testing at that point? And maybe there's not a right answer with that one either, but I just, you know, as things get, you know, we say if practices aren't doing the testing, do they send people to emergency departments if there isn't a respiratory? So say like in somewhere like the St. George area, do you send people to the emergency department for testing if they've got a respiratory?
I'll have another go again. Certainly the imperative at the moment and for the foreseeable future is to find all cases. So we would be encouraging testing of anyone who meets the current testing criteria, and they're fairly broad at the moment. We discourage using emergency departments. So in CESPHN, and I think in Sydney, all the public hospitals have testing clinics. There's the one at Hurstville, there's St. Vincent's. so they're pretty accessible, and of course the ones in general practice as well. And so yeah, until further notice, we'd really encourage testing against the criteria. And I guess it's a bit of a public health plea, but it's always been a good idea for someone with an acute respiratory infection to be isolated at home, because whether it's flu or RSV, it's highly infectious. So it's not a bad principle to follow with all acute respiratory infections.
Okay, thank you for that. We've got a couple of other questions just where people are asking about just a bit of clarification about PPE. And I think this idea of this asymptomatic transmission of sort of people being infectious, is that something that we should be concerned about in our practices? Do we need, and I suppose it could go from everything. Should we have, social distancing in our practice, which I think the answer is yes, but should all our patients be wearing masks? Like where, at what, if there's a whole spectrum of concern about that, where should we be in general practice about the asymptomatic transmission idea? I don't know who'd like to go with that. Owen, that's something that you guys have encountered?
We're very fortunate in the virtual hospital being, connected to all our patients down a camera. I mean, we socially distance through our staff as much as possible, but I'm probably not the best person to comment.
I think, unfortunately, that's another Vicky question.
Sorry.
Look, obviously, as many people have pointed out, we're a very short way into knowing about this virus. In CESPHN, out of our almost 700 cases, we've had 15 asymptomatic cases, and we've had a couple of instances where we thought that asymptomatic transmission may have played a role, but certainly the vast majority of people have a very clear close contact or in a setting where there were other infectious people. So it's not a big issue at the moment, but this is at the time when the disease is very rare in our community. So we may give different advice in 3 or 4 or 5 or 6 months, depending on how the pandemic evolves in Australia. So at the moment, you're very unlikely to encounter someone who's infectious with COVID, and particularly an asymptomatic person who's infectious with COVID. So we'd recommend if your patients have respiratory symptoms that you do take those precautions that Margie demonstrated and Michael described. But for other patients, just the usual social distancing measures are adequate. What we're doing in emergency departments for about 2 weeks now is that staff there routinely are wearing masks and donning full droplet and contact precautions when they're assessing patients with fever or acute respiratory infection. So that's in the emergency department, where they're much more likely to encounter those infectious patients. So I guess translating that into general practice, it depends a bit on your cohort, but keeping a distance and using PPE when you've got people with acute respiratory infection would be my recommendation.
Great.
Can I just make a comment, Michael? Sorry.
Yeah,
washing hands. I was just going to say, in the UK, what they've been doing in some practices is actually bringing their patients into one room where they have a video monitor set up, the GP sitting in the other room, does the history via telemedicine with the patient sitting in the other room, and then they just come in for a quick physical examination, basically to minimise the amount of time they're spending with the patient. And this is a practice that a lot of, I don't know if anyone else has been speaking to the GPs in the NHS, but it's been adopted quite widely just to minimise that amount of contact with the patient. And it only works if you've got spare rooms, but it's just, there's some innovative ways to try and minimise that contact within practice settings.
That is essentially how our respiratory clinic runs. So entirely video and telehealth led, which means we dramatically shorten the amount of time anyone has to spend in a room with a patient. Therefore, we can increase throughput, for the amount of PPE we use, but B, we reduce risk.
Great. Couple of final questions. Sort of one was, is there a cost to testing for people? I know the answer, but no, I didn't. Yeah, but some people, if you haven't, no, in general practice, if we refer to people, there is no cost. And if by chance one of our staff members tests positive, do we have to close our clinic? And I think, Vicky, this is going back to you again. I'm sorry.
Yeah, so if you get a staff member or a patient that's positive, the public health unit will do a risk assessment, and we'll take into account those factors that Michael and Amandit were just describing, how much contact there was between you and the patient, how long they stayed in the waiting room, with your reception staff. So, or if it's one of your staff members, we need to understand all those interactions. So, you know, having a triage system that means that people with respiratory symptoms aren't sitting in a waiting room will help reduce that risk. What we're doing in hospitals is encouraging social distancing between healthcare staff. So if they're doing handovers, don't stand in a little huddle, stand at least 1.5 meters away from each other. So, and so by doing those measures, you will reduce the risk of having yourself and your staff exposed. So just thinking through all those processes. And then, so maybe 1 or 2 staff members might be close contacts. That doesn't mean the practice has to close. Just a regular clean with detergent and disinfectant will clear your surfaces, and then people who aren't close contacts are able to come back. And we've even had GPs who've been close contacts and they've done telehealth from home. So, you know, there's a range of solutions to these situations.
Great. Thank you very much, Michael. And Michael Moore, I might just sort of ask you, is there any, I know the PHN's just done the workforce survey, sort of asking about the impacts of COVID on practices. Does the PHN sort of see any additional support that practices need other than what you're currently doing?
Well, not that I'm aware of. I think, you know, telehealth has been a pretty dramatic and disruptive change to general practice. I mean, you know, we've been talking about it for decades, and now we actually have to do it. And it's interesting that most practices have just gone straight to the telephone, which is, you know, a tried and true technology patented in, I think, 1876. So, you know, we all know how to use the phone. So, but I think we shouldn't lose sight of the fact that video is better. And I think it's really good that Amandit is actually leading the way on that and making sure that people know about the principles of good telehealth care and how we should make sure that we use good products. And I guess one of the things that I would highlight really is the use of Skype and those sort of messaging things as not being a good idea. You know, if you're thinking of going into video, I would strongly suggest people not use Skype and not use WhatsApp or FaceTime, but they go to using a what I would call a proper medium like Zoom or GoToMeeting, or even better, CoView, which is one that's been used for 2 years in New South Wales for remote medicine from teaching hospitals in Sydney, actually also in Brisbane and Melbourne, out to rural and remote areas. So CoView is the one that we're using, that we're promoting. It's one that is supported by Health Direct as well. So look, you know, I can't tell everybody what's best for their needs, and it may well be it doesn't fit in, as Amandit was saying about how it fits in with the stuff that you're using, but it's a tried and true solution, and it works very well, and it has been used by a large number of people locally, and there's a good body of information about how to use it.
And on that note, I think, look, thank you, Michael. We're nearly out of time. I just want to thank you all so much for participating in the panel discussion, and thank for all of earlier our speakers. You've provided a lot of clear information, and I feel a lot more confident to know what I should and shouldn't do when I go back to the practice tomorrow. And that's the point for us all being here. Look, thank you so much for attending. Please keep safe, and you'll receive a link to the evaluation in your inbox. We'll gather all your questions and try and do an FAQ list in the next week, and also post a recording of the webinar. So thank you for your time, and hopefully see you all soon.
Thanks, Michael.